All right. Hello, it's me, Christopher Johnston again. We are going to talk this time about how to develop an effective treatment plan with a multidisciplinary approach. The objectives, we want to understand the importance of decreasing opioid use. We're going to present some of the CERTA concepts in multimodal pain management. And we're going to learn about several specific medications and techniques to add to your pain treatment toolbox. Please, there is an attachment to this lecture that has very specific categories of which patients may be presenting for pain and some great medicines, non-opiate, and in this lecture we'll call them ALTO or alternative to opiate medication options for you. So please reference that attachment to this lecture. But let's dig in. I am an emergency medicine doctor, so we will have some examples and a little bit of some stories from the emergency department. But please, this is absolutely applicable to any acute care or any primary care practice setting. So some cases to Noodle On. 28-year-old male presents wrenching with acute on chronic abdominal pain. Your exam's non-peritoneal. Previous extensive workup the week prior. Has had multiple outpatient CTs in the ED, a GI consult, and the like. The next case is a 34-year-old female with acute on chronic back pain on a regular pain regimen, including opiates for breakthrough pain. And finally, a 65-year-old male who fell on an outstretched wrist presents to you in your practice with an obvious deformity of the wrist. Okay, so again, opioid epidemic. I talked a little bit about this in the previous lecture, but again, just want to drive forward that we are in the midst of an epidemic killing hundreds of thousands of people annually. And as practitioners, as healthcare providers, we are in a unique place to drive and bend this curve back down the other direction and save lives. I think what's important to realize too is for every one of these deaths that you see on this slide, there are 10 people in treatment currently, admissions, 32 emergency department visits, and 130 people who are dependent on opiates, and 825 non-medical users of opiate and narcotics. Okay, multimodal treatment plan. We've got this big, huge epidemic. It's killing hundreds of thousands of people. How are we as care providers going to approach it? And the answer is there are 4 components, 4 pillars to fighting the opioid epidemic. On the top left is limiting opioids. This isn't just in the ED, this is in all practice. Alternates to opiates, which we're going to talk about here in a little bit, the ALTO framework. Harm reduction, so please go back and watch my previous lecture where we talk about this in detail. And finally, treatment of addicted patients and referral. This is medications for opioid use disorder, buprenorphine, and getting wraparound services for these patients that are suffering from substance use disorder. Okay, limiting opioid use. Kind of a no-brainer. In order to fight this epidemic, we need to decrease our prescribing of opiates. I think for us in the emergency department, for example, about 45% of all the patients that present to me in the emergency department have some sort of pain component to their chief complaint. Right now, or at least in 2016, about 25% of those people, 20 to 25%, left with a prescription for opiates. Now, over the last 3 to 5 years, as we've recognized this epidemic and as we've gone and started to institute some of those 4 techniques that I brought up earlier, we are starting to bend the curve, which is great, but we've still got some work to do. Okay, so as we're developing multimodal treatment plans, step 1 is decreasing the amount of opiates that we're prescribing. Now, what's important, and as we start to move into the ALTO framework or the alternative to opiate framework, is understand that I am not here to preach and take away opiates as a medicine for you to use in your pain treatment toolbox. What's important though, and again, I had mentioned this in my previous lecture, only 1 in 5 Americans actually understands the risks and the serious safety concerns around narcotics. And so it's on us to catch those other 4 up, like I had said earlier, but also to treat these medicines with the gravity and discretion that they deserve. Because in addition to their high abuse potential, they also cause confusion, constipation, nausea, tolerance, and withdrawal. They are deleterious. You are actually doing more harm if you use opiates in situations like dental pain, cyclic vomiting syndromes, uncomplicated back pain, headaches. We aren't doing anyone any favors, and we aren't helping our patients if we're prescribing opiates in those scenarios. About 80% of patients who start to use heroin said it started with the misuse of a prescribed opiate, of either themselves or a friend. And for us in the emergency department, 50%, that's half of the patients that I would write a prescription for, or any provider in the emergency department would write a prescription for, 50% of those patients admit to misuse of that narcotic within the 30 days that they left the ER. And that is using that not for acute severe breakthrough pain, but either recreationally or for its euphoric effects. Prescription drug monitoring programs, and I mentioned this a little bit in the previous lecture, are a critical tool when opiates are prescribed. Please, 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 for every script you write, check that PDMP to see the frequency of which someone is getting prescribed controlled substances, the variety of the provider that they are getting them from, and use that not necessarily to preclude or withhold opiates, but to provide an objective construct in which to have further discussions with a patient. I personally use this after talking with the patient. I don't want to create any bias in and of myself before going in to talk about patients. But however, if I'm considering prescribing an opiate, I always check the prescription drug monitoring program in my state. Needless to say, and hopefully I've driven that point, opiates are very, very dangerous medicines that should be used very limited amount of time for breakthrough and severe pain. Well, okay, I just got done saying opiates, use them little, yet I just also said that about 50% of the time, at least for me in the emergency department, patients are showing up with some sort of pain complaint. Don't worry, I haven't left you up the creek without a paddle, and that's where we're going to start talking about the alternative to opiate framework. Pain is complicated. It is more than just sea fires. I burnt myself on a stove. Ouch, it hurts. The spectrum from acute to chronic pain is multiple enzymes, multiple receptors, multiple biomechanisms. There are psychosocial components to this. And so we need to treat pain control with the complexity that it is. And so one way to think about this within the ALTO framework is through a CERTA concept, and that is thinking about different channels, different enzymes, different receptors, and then targeted analgesia. What is causing the pain? And I'm going to specifically target that either biologic or biochemical pathway or that region of the body, whether it be some regional anesthesia or the likes. Now, this concept was initially kind of framed up out of St. Joseph's Hospital in New Jersey, and I think it's important to mention that it was initially labeled as the oxy-free emergency department, and everybody was going around saying, hey, there's an emergency department that is no longer using opiates, and it's called the oxy-free ED. This was an absolute misnomer around what they were doing, and instead what they were doing was creating a framework and educating and making it easier for clinicians to use a lot of these ALTO medicines and procedures that I'm about to talk about. And so that's important to realize. And again, like I said, we're not here to take away your opiates. They are a good pain medicine in the right scenario. But what we are here is to say that maybe there's a lot of different options. And again, refer to that attachment that I mentioned earlier for you to treat your patients that are in acute pain. So when we're looking at CERTA, what it does is it says, okay, we've got all these different channels, we've got these enzymes, we've got receptors, and we've got ways to target this analgesia. And a lot of that is through cyclooxygenase 1, 2, and 3. You have NMDA receptors, you have sodium channel blockade, things like nitrous oxide, and we can inhibit cytokines and inflammation and the like. So what I'm going to do now is walk through a few specific examples on things that we can do, primarily in the acute care setting, but that you can do in your office, in your urgent care or your emergency department, to help treat pain in a way that either excludes opiates completely or decreases the total amount of opiates that we're going to use. So first, I'd like to talk a little bit about lidocaine. It's an amazing sodium channel blocker and is something that we should put in our toolbox for all kinds of different problems, whether it's everything from renal colic to a local cut or fracture. We'll go a little bit more into some of the procedures here in a little bit. But lidocaine is a sodium blocker, but is also a very potent anti-inflammatory medication. Back pain, you can use a 4% lidocaine patch or 5%, which is prescription. I like to use the 4% because patients can get it over the counter. For 12 hours a day at the site of maximal pain, amazing for musculoskeletal back pain. For things like renal colic, you can give it IV, for 0.4% at 4 mg per ml solution, or just use 2%. For primarily renal colic, this showed to, one, improve pain and decrease overall opiate utilization in these patients. I think what's important thing too, especially on the inpatient side or the hospital side of this dosing is way, way low compared to some of the cardiac dosing of lidocaine that we used to give in ACLS algorithms and the like. So know that this is a very, very safe medicine to use. Be careful in cardiac patients when using it, but it's great for renal colic, neuropathic pain, and we'll be talking a little bit on some of the regional anesthesia techniques we can use, and lidocaine would be a part of that. There I have some dosing on a continuous drip if you're admitting the patient to the hospital. The side effect profile is very low, and again, be careful in cardiac patients. Ketamine. This is a little bit of the duct tape of emergency medicine for us. Subdissociative ketamine is a very, very potent analgesic. It is an NMDA receptor antagonist. We give this sometimes in full dissociative doses. That is, if we're doing a procedure, something like intubation, one where we don't want the patient to be present cognitively, but yet they still maintain their respiratory drive. There's some cardiovascular support as well. So ketamine has a lot of utility for us, specifically in the emergency department, but maybe also for you in the urgent care, acute care setting. Subdissociative dosing, you can see there's about 0.1 to 0.3 mg per kg, and you can give that as an IV push. Several randomized control trials that are showing effectiveness. Caution in patients with PTSD. I think for using this, particularly with dissociation in the emergency department, the patient's mental state in which they go into a dissociative state is often the one in which they emerge. And so you want to get them actually in a good place. I'll usually bring the lights down, have them think about something lovely, and have that be where they're going when they're dissociative. When we're doing subdissociative dosing, that is to help in acute pain, the key here is to go the lowest effective dose and to push slow. Ketamine is non-inferior to morphine and is one of the medicines that when given with opiates actually decreases the total amount of opiates needed, particularly in some elderly populations. This has been shown. So ketamine, I said there is this dissociative state. Sometimes we call it the K-hole. You may have heard that. And then there's this subdissociative state, which is the one we're talking about here to use in acute pain settings, or even somebody coming in with an acute on chronic pain syndrome like chronic abdominal pain, chronic headaches, or migraines. The one thing we want to do, and this picture illustrates it, you want your patient to be a part of this crew here. Sitting around, that's the K-hole in the middle. They're standing around, appreciating the K-hole. They aren't in it, but they are on the outside appreciating it. And that, again, is with low doses, and you can push it slow. Sometimes that 0.1 to 0.3 mg per kg you can give over 15 minutes or so. You can be in the hole, which is full dissociation. Again, this is about 1 mg per kg, and we use that a lot in the emergency department for really painful procedures, or to induce prior to intubation. The one thing you really want to avoid is your patient hanging onto the edge of the hole for dear life. And what I mean by that is there is a place between subdissociative dosing and a full dissociative dose that will make your patient very, very uncomfortable and probably turn them off to the potential of using ketamine ever again. And so please, I just want to warn you, use low, give slow, and you'll avoid that person going into a place that they never wanted to be and hanging onto the edge of the hole for dear life. So that's ketamine. Trigger point injections. So this pairs with the sodium channel blockade that I mentioned earlier. You can use lidocaine. You can use some longer acting. I like to use bupivacaine, 0.5%. And you just use a small amount. And this is amazing for myofascial pain, headaches. If a patient comes in with point reproducible pain in their back or paraspinal area, some trigger point injections at the base of the skull can sometimes often help with migraines or tension headaches. It's often 0.2 mLs IM of lidocaine and bupivacaine locally, and you can do a few sites. What we've also seen is that through the gated theory of pain, that even dry needling or the needle itself going into the area, although there's the prick and some of the initial noxious stimulus, can also help with some of these localized myofascial pain syndromes. And so trigger point injections are great. One thing to be real cautious of when doing trigger point injections, especially in the upper lumbar spine or in the thoracic spine, is avoiding, of course, getting into the thoracic cavity and causing a potential iatrogenic pneumothorax. The best way to do this is to kind of bunch up the soft tissue in which you're going to inject and then inject parallel to the patient's back so that you aren't actually going in or perpendicular and carrying a risk of potentially dropping a lung in that case. But other than that, these are relatively very, very safe injections and is usually just a small amount of anesthetic is all that's needed. Ultrasound-guided blocks and regional anesthesia. We now, with the help of ultrasound, can identify both compartments and specific nerves to knock out and anesthetize. And these are great for a patient, let's say, that has a large laceration on the bottom of the foot or a fracture of the leg or femur. You can, with ultrasound guidance, deliver either a localized amount of lidocaine or bupivacaine in these cases around the nerve sheath, or in some cases, like a fascia iliaca block, do a large volume compartmental block that'll anesthetize several nerves in the area and is great for some fractures that you may see. So regional blocks, it's important. Here's a quick safety list. Make sure the patient, of course, is not altered. Informed consent obtained, either written or verbal, depending on your institution. These are still procedures and should be treated as such. Make sure you perform a neurologic exam prior to anesthetizing or doing a nerve block to document that it was intact before you began the procedure. Make sure there's no signs of high risk or compartment syndrome, particularly in fractures, that there's no signs of infection at the site of needle insertion. Make sure that there's no severe coagulopathy, no severe immunosuppression. Discuss the block, of course, with any admitting or consulting service or any other doc that you may be interfacing with or APP. Know the patient's maximum safe anesthetic dose. Harbors back to some of my med school days. And make sure the patient is on a monitor and that some of the resuscitation equipment and if needed, intralipid is available. And this is particularly for the large volume blocks should you get it intravascularly on accident. Nitrous oxide. More common in pediatric EDs and as well as in some of the outpatient settings. It is amazing procedural sedation with rapid onset, rapid elimination, easy. You titrate right up to 70%, get the patient in a little bit of a euphoric state, and usually for either procedural or sewing up lacerations or doing things like that is a great way to avoid needing to use any opiates. All right, some good old-fashioned medicines for you. So non-steroidal anti-inflammatory drugs, or NSAIDs. These are amazing. And I know sometimes, despite it being over-the-counter, our patients don't necessarily understand this, but these are very, very effective pain medicines and anti-inflammatory medicines. And that's everything from ibuprofen all the way to Toradol. Cyclooxygenase is what you're inhibiting with this, of course. No, specifically with Toradol, higher doses than 15 milligrams we found are actually increase harm but don't increase efficacy. I think another important thing to realize with Toradol is that you are not going to increase the risk of postoperative bleeding or bleeding complications with one dose of Toradol for an acute pain presentation. You can use for musculoskeletal, migraine, renal colic. It is absolutely amazing, specifically in renal colic, because it not only decreases pain, it decreases spasticity of the ureter and decreases inflammation around the site. Also has a little bit of decrease in the patient's GFR, which helps decrease the pressure behind an obstruction in the ureteral anatomy. Toradol. Amazing medicine. Also, if you don't have any reason to think that the patient has renal failure, you don't need to wait on a creatinine to come back or to assess the patient's kidney function prior to giving Toradol. It's okay to give it up front if the patient's presenting looks like renal colic. Caution in geriatrics and renal dysfunction as well. Topical diclofenac gels and patches are also a great way to treat local arthritic complaints and musculoskeletal pain. Haldol, IV, IM, or oral, 2.5 to 5 milligrams for abdominal pain or migraines. This again pain is complex, and Haldol is a pain medicine when used in the right clinical scenario. If a patient has an allergy to Haldol, you can use olanzapine if that allergy was not extrapyramidal. Be cognizant of some QT prolongation. Some hospitals and states will require that you check EKG either before or after to see what their QT is, and is amazing somatic pain control through dopamine. One quick note too, and this is particularly with lidocaine and ketamine, which I talked about earlier. Make sure that your hospital policies, procedures, or your state's policies and procedures around these medicines know them, as some of them can limit or dictate the way in which it's used. But what I would say is advocate for these to be used in your care setting as long as it's safe to do so. So finally, some special populations. Always be careful in geriatric patients. Dicyclomine, Haldol, Benadryl, muscle relaxants, NSAIDs too, just from a gastric bleeding standpoint. Always just give second thought when prescribing these alternative to opiates to geriatric patients. Those people with renal dysfunction, those patients with renal dysfunction, be cautious with NSAIDs. Heart failure, caution with NSAIDs, and then pregnant patients, of course. Make sure you're really looking at the pregnancy category and making sure that what you are giving is safe for the pregnant patient. And finally, in pediatrics, just make sure that the medicine is safe and to utilize weight-based dosing. Okay, so hopefully throughout all of that, you've noodled and you've thought about these cases that I presented on the front end. So the 28-year-old male who presented with retching acute on chronic abdominal pain had a non-peritoneal exam, previous workup for the week prior. This is an amazing case to institute either Haldol, droperidol, low-dose ketamine are often very, very effective in these patients. They get into a very relaxed, resting state, and within 30 minutes to an hour wake up and feel great. Their nausea and pain has been controlled. Our 34-year-old female, acute on chronic back pain, has a regular pain regimen, including opiates for breakthrough. Consider some trigger point injections like we talked about, a lidocaine patch, NSAIDs, and then ultimately a lot of back pain is improved with some solid back strengthening exercises, and you can educate the patient on those. And then finally, our 65-year-old male fell on outstretched hand with an obvious deformity of the wrist. This is one where, yes, maybe acutely some opiates may be warranted, but you can actually decrease the amount that you're going to use with medicines like subdissociative ketamine. Or consider some regional anesthesia, whether it's a nerve block, median nerve block, or in these cases of a wrist fracture, I love to do hematoma blocks, which is a little bit of a large volume infusion at the site of the fracture. It's very, very effective and allows you to reduce the fracture, get proper alignment and splint, oftentimes without using any procedural sedation. Thank you so much for the opportunity. Again, remember to utilize these alternative to opiate therapies, the CERTA concepts. Please limit your opioid use as much as you can for acute, severe breakthrough pain. Check the attachment. There's some great stuff there on some medications and procedures that you can use in various clinical situations. Know that we're not telling you to remove opiates completely, but to be very, very prudent, because as we said at the beginning, and the whole point of this entire lecture series is to fight this opioid epidemic head on, and you as a clinician are at the front lines of that. And so thank you so much for your time.